So we've got questions from people who are not newly diagnosed because, as I said, Katherine is the expert. So I'll let Katherine start. Thank you, Katherine.
Hey, thank you for that introduction. That's very kind of you. I'm going to start my slideshow, and hopefully you won't hear my dog whinging. He's decided to have a bit of a complain about something, but I don't know what. Right. So
Katherine, we're still seeing a little bit of a black box at the top of your
are
presentation.
you? Okay, if I cut that and then there's that. I don't know why that's not gone down. There we go. Okay, right. And yes, it's working. There we go. I'm going through now. So I've got this slide in at the start because I think as a geneticist, I see people with lots of different rare diseases. And when we talk about rare diseases and what happens to people with them and what we know about them, there's always some limitations in what we're able to say. So if you've only got small numbers of people, if you have challenges collecting evidence because they're separated across a country or even across the world, and then generating the level of proof that we need in order to develop guidelines and so on can be a bit of a challenge. And that's why this group's so good, because things move forward much better with some patient power behind them. Your voices are really important. And I've been listening to a talk today about the Rare Disease Action Plan, and there was quite a lot about care coordination in that. So it feels like there's movement, even if it feels a little bit slow. So I'm going to start with a sort of history lesson. So it can be a bit confusing when you get a diagnosis of a condition associated with the PTEN gene, or if you've had it for a long time and you hear lots of names associated with it and wonder which one you have or why we keep changing our names about what to call it. So this is just a little lesson about that, which I hope helps a little bit. So in the past, what happened was we had these conditions called Cowden syndrome described, and that was described by a dermatology team about a young woman who had breast cancer and had some specific skin lesions that were unusual. And so they wrote about her in a medical journal because they thought that she must have a condition that was caused by genetics, but at the time it was long before we were able to do any testing. This Banyan-Riley-Ruvalcaba we often call BRRS, and this was described by several different doctors, and then the name is an amalgamation of their surnames put together to recognise their contributions. And those authors described children with big heads, with some skin signs, and with some learning difficulties or autism, although they might not have called it that at the time. These other conditions were described, so autism and macrocephaly running along together. I'll talk about Lemaitre-Duclos in a little while. So this is a very specific growth that happens in the back part of the brain called the cerebellum. And then these other syndromes, which look quite different, but are often due to overgrowth of just some cells on a background of somebody having a PTEN gene variant. And what we do over time is say, well, actually, all these different conditions are due to changes in this gene, which we found out later. And so we put them all under one umbrella and call them PTEN hamartoma tumor syndrome. But you might still hear people talking about these diagnoses, and certainly between doctors, it's really helpful, because if we say, I've got a patient with Cowden syndrome, we'll make an assumption that they're an adult, and about how that diagnosis was made, in the same way that if someone says to us, I've got a patient, I think they might have BRRS, you assume that they're young with a big head and perhaps with some other skin signs. So we still do split them up to some extent, but because we can't differentiate between them in terms of what screening people should have and so on, we put them under this one umbrella of PTEN hamartoma tumour syndrome. Oh, I've got some extra slides in here. I didn't have to remember it all. So I'll just whiz through these. And so you can see a little bit more detail about some of those. So when we make the diagnosis in children, often those children, if they're referred to genetics, it'll be because their paediatrician has recognised that they've got often some developmental delay. They may have noticed that they've got a large head, and they may have noticed some of these skin features, in particular these lipomas, fatty lumps, vascular features. So those can be red or purple, and occasionally gastrointestinal polyps. And a combination of those things together makes us think of the diagnosis. Before we had very broad genetic testing that would look at a lot of genes all at once, so whole genome sequencing, if we saw a child with autism or developmental delay or with macrocephaly, we would order a PTEN gene test. That was enough to make us think about it. And about 20% of children with a big head and autism have a PTEN gene variant. Can you hear my dog whining, or is it okay?
A little bit, but it's okay.
A little bit. I'm really sorry. I don't know what's the matter with him. If he carries on, I'll have to go and get him a biscuit. So, so this slide's getting quite technical, but these are the things that in an adult would make us think about a PTEN gene diagnosis. Just excuse me one moment. I'm going to go and get him a biscuit, and hopefully he'll be quiet. Rhodey, come here.
It's really
I love a
cute.
biscuit too.
Yeah, I know, right? We'll cut this bit out of the recording.
He's going on a treat chase, and hopefully that'll keep him happy. So, right, let me carry on talking to you. So, this slide describes the things that would make us think about testing the PTEN gene in an adult. It's a slightly outdated scoring system now because it doesn't include the vascular malformations, and some of the things on here have been removed from the diagnostic criteria as well, but it's still really useful in helping us think about whether it's the right test to do. And then these are criteria that come from the States, are updated every year or so as new evidence emerges. And these are for testing criteria, and we're just in the process of rewriting the UK testing criteria at the moment. I'm going to move on and do a little bit more about chromosomes and the genetics now. So these are male chromosomes here. You can see that they come in pairs, and that there's an X chromosome and a Y chromosome here. We can't see them like this in our cells. They've been specially stained. And this is a test that's not used very often anymore, but it's a good way of showing people what our genetic material looks like within our cells. So I think I've said most of that. So our chromosomes contain our DNA. They are in a linear order, but they're all mixed up. So it's not as if there's one chromosome for eyes and one for heart and so on. It's completely random how they're organised. And there's 23 pairs, and we get one of each pair from one parent and the other one from the other parent. Okay, so There's just a few examples of where different genes are. And then the PTEN gene is actually on chromosome 10, although that's not why it's called PTEN. And in order to have the condition, you have a variant, so shown by this little yellow mark here. You have a variant which is an alteration in the usual spelling of the DNA in the PTEN gene. There are a few people who will have the diagnosis because they have the whole gene missing. But for most people, it's caused by an alteration in the spelling or the code of the gene itself. Okay, so what do genes do? This is quite important in trying to think about how they work or what happens when they don't work. So genes code for proteins. They give an instruction and they send their messages through RNA to tell the cells to start growing a protein. And so if there is a change in the spelling of the gene, that has an impact down here, and the protein doesn't form in the way it should do. It might be missing altogether, or a big section of it might be missing altogether. And then the gene doesn't work in the way it should do. So when a gene's working in the way it should do, we have a functional protein from it. And when we have a gene that's not, it either doesn't work properly or it's missing. Okay. I'm just going to whiz through these ones. So ignore the male at the bottom there. That's just, I don't know why that's appeared there. So it's the same for males and females. PHTS is a dominant condition, which means that we just need one copy of the gene to be altered or have a spelling alteration in it to have the condition. And there are different forms of inheritance, so recessive inheritance, where you have to have two copies of an altered gene. So one people might have heard of is cystic fibrosis because it's relatively common. And then I've realised why it says male there now. So X-linked conditions are conditions that affect males, but because they have an X and a Y chromosome, just having an alteration in their one copy of the X chromosome is enough to give them that condition. But the one we think about for PHTS is dominant, autosomal dominant genetics. So what does this look like? If you've got a family history of the condition, then the altered gene might be passed from parent to child. It could just as easily be the mother to the child. It's just an example here. Okay, and then this is a slightly more complex diagram, but it's helpful in showing us what the chances are of that happening, because if you've got an alteration in the gene, you can either pass on this copy with the alteration in, or this copy without the alteration in. And because it's a rare condition, it's reasonable to assume that the other partner doesn't have the condition. So you're always going to get the usual spelling of that gene from their partner. And that means that there's a 50-50 chance of it being passed on every time you have a child, if you have the condition yourself. Okay. And this is what it might look like when we draw a family tree in clinic. It's very rare that we can go back through this many generations and have this much information. But we see it passed down through the family. We see it being passed between male to male. So that gives us a clue that it's this pattern of inheritance. But one thing we don't understand so well is why we see different issues in different members of the family with exactly the same gene alteration. And so it can vary between parent and child. So you might have an adult who has no learning issues, no signs of autism, and is diagnosed in their 30s or 40s. And often that explains things that have happened to them earlier in their life, but they've never been unwell enough or seen a doctor who's recognised the pattern to get a diagnosis. But their child might be presenting with developmental issues, a big head, and so on. And the child may be the prompt to get the diagnosis in the adult. And of course, it can happen the other way around as well. Okay, I think that slide's in twice. PTEN gene changes don't always have to be inherited from a parent. They can happen for the first time in someone. And certainly in my clinics, this is a very common way that genetic conditions occur. There's no family history. People will say to me, this has come out of the blue, is often a phrase that they use. And the person diagnosed is the first person in the family to have the PTEN variant. It's caused by that variant, the spelling change happening when the genes are being copied to make the egg or the sperm cell that goes to make that person. And it's nothing that the parents do or don't do. We see this with thousands of different genes. And it's a really complicated process to copy all that DNA and for it then to go on and make a baby. But once that person has the condition, they then have a 50-50 chance of passing it on. But the parents who don't have it have a low chance of having children with the condition. There's a little bit more to that. So if that's something that is important to you when your child's being diagnosed, that's something that a geneticist or a genetic counsellor will talk to you about in more detail to make sure that you understand it fully. Okay. So just as a bit of a summary of that, if you've got a PTEN gene change, there's a 50-50, 1 in 2 chance of passing it on to your children. It's the same chance every time, just like heads or tails with a coin. We can't predict the severity. So just because a parent doesn't have significant learning or developmental issues doesn't mean that the child with the condition won't. But it is possible, if it's something that people want to consider, to have prenatal diagnosis, so testing during a pregnancy, or to have pre-implantation genetic diagnosis, which is a IVF procedure where only embryos without the genetic condition are put back into the womb. And genetic counsellors can talk through all those options in detail. In my experience, people make all sorts of different decisions. Some people carry on and have children and think that the most important thing is just to let nature take its course, whereas other people feel very strongly that they don't want to pass it on and will consider other options. And other people make different decisions. So you could consider, depending which parent has it, something like sperm or egg donation. And some couples decide to adopt instead. Okay. I'm not going to go through a lot of detail about the gene. I think Priyanka talked about this in some more detail last time, so I'm going to skip through these slides a bit. Now, this is something that we often get asked about. So what does my genetic report mean? Or not having a copy of the genetic report and wanting to have that information. So at the moment, knowing exactly what the genetic change is that you or your child has won't change what we do in terms of management or surveillance, but it could be more useful in the future as we learn more about the gene. So what this tells us is that this is the gene where the variant's been found. It tells us the position in the gene, and it tells us the exact genetic change, and it tells us the impact on the protein as well. And then from there, the scientists in the laboratory will compile evidence to tell us whether they think they have enough evidence to say that this is definitely the cause of somebody's health or developmental issues. So I'm not going to go through that in lots of detail, but the important thing is that if your report is saying it's pathogenic or likely pathogenic, then we have enough information to say we've confirmed the diagnosis. Okay. Shall I just keep going for now? Just tell me if you want me to stop and move over to doing some more questions.
It's 53 past, maybe for another 5-7 minutes, and then we can start the Q&A.
Yeah, that's fine. Sometimes I think it's helpful to hear about other families and what's happened, and I think that's one of the really important functions of the patient group as well, being able to meet other people and share experiences and not feel lonely in having this rare diagnosis. So this was the first family I met. This little boy was 3 when I first met him. He had developmental delay, a big head, and these fatty lumps on his body called lipomas. They're harmless, but depending how big they are and where they occur, they can cause more trouble. When we drew the family history, his mum also had a big head, and she'd had trouble with thyroid nodules and had had part of her thyroid removed when she was in her late teens. She also had lots of facial papillomas, so her skin surface was a bit bumpy and uneven, and these probably represent the skin findings that when you look at them down a microscope, a pathologist will call a tricholemoma, and it's a very specific appearance of the hair follicle, and that is a hamartoma, so that means an overgrowth of the underlying tissue happening in a hair follicle. So her sister, very sadly, had died suddenly of Lemierre-Duclos disease. This is a rare thing to happen, so I think it's really important that I reassure everybody about that, and also that this was a really long time ago now as well. We're going back probably the best part of 30 years to when this happened now. She hadn't been diagnosed but had been developing symptoms of headache and being a bit unsteady, and the growth grew too big before anybody recognised what it was. Now I think it would be picked up on scanning and treated appropriately. And their mother had died of breast cancer, but she had also had thyroid cancer. So you can see that this family on its own demonstrated lots of different issues that happen in people with PTEN, but all of them had different issues from one another, even though they have the same diagnosis. And the way I don't know if it quite works as an analogy, but if you look at the side effects for a medicine, there will be lots of them, and they'll separate them out on a leaflet in the packet into common ones, things that happen fairly regularly, and rare side effects. And you can think of things that happen in a syndrome as being similar to that. Some of the things are common, like having a big head. Some of them happen to quite a lot of people, but not to everybody. And some of them, like the Lemierre-Duclos disease, are very definitely associated with a condition, but nonetheless rare, even if you have it. Okay. I think this might be helpful just to go through. So about 10 and 20% of children with autism and a big head have a PTEN gene alteration. So we're always quite keen to raise awareness of that. And particularly now that genetic testing isn't offered for people with just autism. They have autism and developmental delay, so they've been late to walk and so on, then it would be offered. But autism on its own is not enough to trigger genetic testing. And so I talk to doctors all the time and say it's really important that if you're making a diagnosis that you notice if somebody has a really big head, or ask them about it, or even measure it, because that's probably one way that we are missing diagnoses in people. Okay. I've got a picture of a lipoma here. So this is what it looks like. It's skin coloured. It's very soft when you touch it. They're not painful. It can be hard to decide exactly where the edges of it, although you can see them. And they can grow really quite big, or they can be very tiny, less than a centimetre. They're harmless. They don't cause problems in themselves, but they can be unsightly, or if they happen somewhere like where your bra straps rub or on your foot, they can be incredibly annoying. And so there are times when we do think about removing them, but we're not anxious about them from a cancer perspective. And of course, if you have this condition, that's often something that worries you if one of these things crops up anew, that wasn't there before. And it's always important to get it checked out, but if that is what it looks like, that is quite reassuring in itself. This is just a picture of the appearance of an MRI scan. So if I just orientate you a little bit, you can see an eye and the teeth here. This is the back of the head, and this is the main part of the brain called the cerebellum. And the bright part around the edge, of course, is the skull. And then this is showing it sliced in a different direction on the scan. And it's much easier to see here. This again is the back part of the brain called the cerebellum. You can see the eyes and the nose and the sinuses at the front here. And it's this part here, this bright part that looks very stripy and is well highlighted, that is the growth here. Sometimes nothing is done about them. Just watch and wait. And if they're not causing new symptoms, not causing pressure in the head, which you might notice if your optic discs are commented on by your optician, or if you're getting more wobbly on your feet, then often they'll just be monitored and nothing happens. But if they do grow, then there are different options for treatment for them. Okay. This is a picture of somebody's leg, so another scan to orientate you with. So sometimes we see people with overgrowth of part of their body when they've got a PTEN change. I don't know exactly how often this happens, but I think we are getting better at recognising the diagnosis when this is the main problem that somebody has. And when we look at a scan of the leg, it's this area that's unusual. And instead of looking like this, so this is a muscly part of the leg here, and it's all a fairly uniform colour, you can see that there's lots of different areas. It looks a bit disorganized, and that's because there's fatty growths and blood vessel overgrowth within it. If this isn't causing any symptoms, we wouldn't do very much about it other than monitor it. But if they're causing pain or trouble with mobility, then there are various different options for treatment for them. And then these are what the vascular things can look like. They can be really small, so you can just see one here. This is a neuroma on the palm of the hand. You can see one here, it's quite subtle, and then growing down the arm a bit. And then these ones have had surgery to remove part of them, but you can see there's still a little bit left to one side there, because it can be really tricky to remove them. Often now they're treated by radiologists rather than with surgery though. Head circumferences, this is from my study when I was a registrar, so this is older than I'm going to admit to now. You can see that the head circumferences for all the people we saw are big off the top of the growth chart. And then the adults are all plotted here because we don't have charts for adults. And you can see that they are all off the top of the chart. And it was the same for girls and women as well. Okay. I'm going to whiz through the MRI changes. We can come back to those. Tonsils are something that's come to light a bit more recently. So one of my patients was diagnosed by an ENT surgeon because he'd seen other patients with the condition, and he noticed that the patient he was seeing had a really big head and the most enormous tonsils, and was snoring and having trouble with hearing, and with recurrent infections. And we see this really commonly in children with PTEN. And we published a paper on it a year or so ago now. I think it is important to recognise, because if it is causing problems, particularly with sleep being unsettled, not getting enough oxygen while people are asleep, they feel groggy, don't learn as well at school, might be rather grumpy, and there is a risk, if they're left to grow too big, of them causing a bigger problem. So I think it is important that we highlight this as something to look for, and to refer onwards for. I'm going to whiz through the skin features, Priyanka, and then I'll stop. Is that okay? I think there's about 6 slides.
Sounds good.
Yeah, because I think these are things that people often want to know about. So this is in a child. You can just see them around the nose. This is on the forehead, and you can see just this very slightly bumpy appearance, but they're not, the little skin lesions are the same colour as the skin. And you might notice they've got just a tiny pearly lesion in the middle of them. Sometimes we call them papillomas, and that's because they've got a slightly different colour to them. And you can see they've got more prominent on this person as they've got a bit older. These are what they look like on the feet, and they can be quite subtle and difficult to notice. But you can see again these little round lesions, and if you zoom in on them, you need really good light to look at them. The edge is slightly raised, and they've got a slightly pearly appearance to them. And they seem to increase in number as people get older, but we do see them in children if we look carefully. But again, they're harmless. They're not cancers, they're not anything to worry about. Occasionally, though, as people get older, they get bigger and can be more uncomfortable. They're sometimes mistaken for verrucas, although they respond reasonably well to some of the treatments to reduce the size of them. And podiatrists can be very helpful in treating these. And then just a few more pictures of them. These are in a child, and they can be confused with verrucas. Teeth and gums can be an issue. So teeth, in the sense that if you've got gums that are overgrown and lumpy and bumpy, it can really affect your dental hygiene and cause decay and teeth problems. So this is in an older person, and these changes gradually accumulate over time. It's not very easy to see in this. This is in a child, and you can just see it on this surface of the gum here, just the inside of the mouth looking a little bit bumpy. And then people's tongues sometimes can become bumpy as well. And if you get one of these little growths on the end of your tongue, they can be really irritating. And I've certainly asked maxillofacial colleagues if they'd be kind enough to remove these for people in the past, because they're just annoying. Okay. This is a sign that's important to recognise. So people might say, oh, well, people keep saying that I've not washed properly because my neck looks dirty. This can happen under the arms, and you can see this on an elbow as well. And it's called acanthosis. We see it in people with diabetes, type 2 diabetes, but in PTEN it seems to be rare for people to develop that type of diabetes, but they do show the skin signs of it. The gene acts in the insulin pathway, so I'm sure it's something to do with that, but working out exactly why is more challenging. So it isn't anything to do with washing, it's a sign of the condition itself. Okay, I'm going to stop there, and I can answer more questions or go through some of the other slides if that would be helpful.